truncate some of my presentation because actually some of the themes have already been referenced. And what I want to do is talk a little bit about some research I've been conducting that looks at the intersection of domestic violence and HIV. Most of my writing has really been in the area of domestic violence, violence against women and girls. But at some point, as we really began to look at the population, the women we were working with, it was clear that we had to look at the intersection of HIV. And as I talk with you a little bit about why, I think you'll be able to begin to see some of these intersections. And I like the fact that Dr. Fairfax referenced the word intersection because I'm going to spend a bit of time there. This study was actually funded by NIMH. It's through the HIV Intervention Science Training Program that's housed at Columbia University, School of Social Work, the Social Intervention Group, and Dr. Nabila El-Bassel is the principal investigator for the HISTP program. Just to kind of contextualize some of this in terms of HIV and violence against women here in the United States, that while African American women represent 13% of the U.S. female population, they represent 63% of HIV cases. I mean, I think that's just absolutely staggering. That's 3 times the rate of infection for Latinas and 23 times the rate of infection for white females. 64% have become infected as a result of heterosexual contact, with most being infected by their primary partner. Again, I think these numbers are absolutely staggering. I want to talk about this in the context of Washington, D.C., where I spend a good percentage of my time. And I'll talk a little bit about some of the domestic violence statistics and some of what we know about HIV in the district. But domestic violence accounted for 1/3 of violent crimes in the District of Columbia in 2005. Every 19 minutes, the Metropolitan Police Department receive a phone call that's related to domestic violence. I mean, think about that within the context of the 90 minutes that we're together. And the calls have actually increased, you know, over the past 3 years, 22%. What's interesting about that is there's been some discussion from the National Institute of Justice that domestic violence rates are actually declining, which a lot of us don't believe. But clearly, if that's true, we're seeing a clear increase in the district. And there were 51 murders in the District of Columbia in 2005. Due to family violence-related crimes, and 1/3 of those were attributed to domestic violence. That's from what we know, and some of you may know that in police reports, you know, oftentimes you really can't discern if domestic violence was an impact, and we've seen some of that actually in the past week in a really highly publicized case of what we think to be a domestic violence-related homicide, right? Let me talk a little bit about HIV in the District of Columbia. And this was quite shocking even to us, those of us who live in the area. According to the CDC, the District of Columbia has the highest rate of HIV infection in the United States. And I'm not going to go through all these statistics, but let me say this. 75% of the women in the district are infected through heterosexual transmission. We know this. While African American women compose 62% of the female population, they represent 90% of women that are living with AIDS in the District of Columbia. So that's my motivation for looking at this intersection. We know that women's vulnerability is enhanced when you look at the intersection. Having a lack of power and financial independence, Dr. Perry talked a bit about that, and not having the decision-making ability to access and adhere to treatment. When violence is a part of that relation. The fear stigma that Dr. Fairfax talked about, the fear stigma is not just in terms of the domestic violence, but also HIV. The fear of discrimination, I'll talk a bit more about that. The cost of services and drugs, what it costs to be able to be treated, what it costs to be able to access care. The geographic inaccessibility of services. You know, we have folks, you know, who, and I don't think this is unlike many other parts of the country, who in the district may have never left the ward that they've lived in. I mean, literally, you know, they have stayed in Ward 7 and they've never left Ward 7. So going out to Ward 2 or 3 to get services is really viewed as a challenge. And then some of the gender norms and inequalities that Dr. Fairfax talked about are quite relevant, and I'll talk a little bit more about that from the women that we've interviewed. I'm not going to talk specifically as much as I'd really love to with this slide. I'm going to show some discipline today. But we know that there is an intersection in terms of culture, right? We are very clear that culture impacts how we seek help. We call that delayed help seeking. Dr. Snowden is going to be here tomorrow morning, and I know he's going to talk about delayed help seeking and mental health. But we clearly know that there's a delayed help seeking, being that oftentimes African Americans and African American women do not access care as quickly as they ought to. You know, for example, I know that I have this issue. I'm just not going to ask anybody for help because I got a lot of other stuff to do today. Or any other range of other reasons, some of which I'll talk about. Coping strategies. Dr. Fairfax talked about the importance of the church and the importance of faith-based communities. So we also know that the coping strategies, how folks cope with what they experience, also has a cultural dimension. The perceptions of formal systems I'll talk about because our participants gave me some quotes that I could actually use today. A heightened sense of secrecy and shame. Again, somewhat, already referenced. But, looking at the secrets that many people house and the shame associated with that. Another clear area for us to look at. The fear of discrimination, the fear of being treated in a discriminatory fashion. I'll talk about that, but one of the clear things we know is, for example, in domestic violence literature, we know that women who are African American are more likely, if domestic violence is found in their home, to have their children removed, to go to prison themselves, to have their partner be incarcerated and charged as well. We also know that they're more likely to experience discriminatory treatment from service providers. So we're really clear on that. We understand that there's that other dimension of the fear of discrimination. This role playing between the balance between family and community is also another clear issue. So in the domestic violence literature, we talk about racial loyalty, meaning that it's really difficult to ask an African American woman to, quote, betray her community by talking about a lot of these issues. And so oftentimes that balance between self and family and community become really challenging in being able to address some of these complexities. The intersectionality of oppression, which I think is really critical for us to understand. I think everything that you've heard in terms of looking at issues of race, ethnicity, class, sexual orientation, just an enormous gender oppression, just an enormous complexity of intersections, right? And then historical trauma, which I'd love to spend some more time on, but I think that when we look at what's often talked about as historical trauma in the Native American literature, one of the things that we clearly can see is that there is an historical trauma, there's an historical context. So even when I talk about what my research has focused on, you'll hear folks reference historical issues like the enslavement of African people and what that has done to current relationships. You're going to hear me reference the Tuskegee experiment. Again, not something that's happening now, but there's an historical trauma that I think that we often miss when we're working with our clients and with folks who engage in research with us. So I have to, illustrate the womanist perspective, because I think the womanist perspective gives us a framework for really understanding these issues. Womanism calls for an understanding of the nature of race, class, and gender oppression that women of African ancestry experience. And it stresses the importance of looking at the multiple layers of oppression and telling one story. It stresses this idea of healing and transformation and liberation, not just for women, but for all humanity. And so I think that as we center the discussion there, it helps to illustrate or to see some of the interlocking systems that we'll talk about. So let me briefly talk about what we did. I'm going to skip through a bunch of slides, right, so I can get to what I really want to do, which is share what the women said. We did a four-stage approach to focus groups. We did some focus groups with African American women, and the four-stage approach meaning that instead of having different groups of women at each focus group, we had the same women participate in each focus group, okay? And so the first focus group, we looked at HIV and domestic violence and their perceptions and experiences with HIV and domestic violence and what they thought about the intersection. Not just these two separate issues, but how they converge. We did two other focus groups. Our second and third group looked at the cultural context of HIV. The reason we did that is because there's been lots of research that's been done on African Americans and HIV and perceptions, experiences, and so forth. But what we really wanted to understand was, how do African American women really see this, and what is their perception of the cultural context?